Thanks so much. It just clearly a lot of content-laden discussion there as far as endocarditis patients are concerned. Clearly, a drag to society economically, and we've got to intervene earlier on these folks, both from a behavioral standpoint, but then also when they get their valve issues. So we got about 5 minutes for just very focused discussion. So I would like all the distinguished members of the panel to comment broadly on a couple of different topics. So one thing that I've noticed with these mitral valve repair replacement trials, Conrad and Jeff, is that we're actually inaugurating new technology within the constructs of these studies, and then we're also changing the study designs as we move along. So what was a randomization of surgery then becomes maybe a tier exclusive cohort with maybe future development more towards tier randomization, that sort of thing. How are we going to interpret these results at the end of the day? More for the replacement studies than obviously the tier studies, but as we inject new technology and change study designs, what exactly is that going to lead to scientifically?
Yeah, no, I think it's a great question, and I think in part, this has become the case as the tier technology has shown evidence of benefit in earlier studies and in clinical practice. So in some patients, it was not felt to be reasonable to randomize them to have not have tier as a reasonable arm for randomizing those patients. But I think it's a standard of care. It's what we're dealing with now, and I think it was an important step for both enrollment in the trials, but also in as we're looking at patients, what are the options that patients have moving forward, and how that is going to define the true utility of these valve replacement therapies. As Jeff mentioned, I mean, it's a tough field. It's a very tough field with respect to the number of patients that are not deemed eligible for anatomic reasons or for other reasons. So our ability to sort of maximize and optimize the number of patients that we're able to enroll in the trials and look at the data down the road to see where we are. I think you've experienced it as well in the work that you guys are doing, and I think it's not only is it the challenge in enrolling the patients, but it's the modifications of devices and approaches that are going to make it a challenging field, and I think a field that we still have a lot of work to do.
Jeff, you have any comments about that? The transformation within studies, new devices getting injected in, study paradigms changing?
Yeah, I mean, I think it's gonna be an iterative process, and as we get new devices that become more of the standard of care, we're gonna have to compare it against that new level. And so, I mean, I think this is probably not going to be handled as much in randomized control trials, more in real-world registry data as we get commercial devices that are on the market and we see how they respond, kind of in a real-world anatomy with different techniques that we're using to be able to use an individual device that maybe wasn't studied in the randomized control trial.
Yeah.
So, I mean, I think it's just going to keep evolving as we go and we get more devices commercially available to use.
That's an excellent point. And I mean, I just think that this is like apples to oranges at this point. So we're really transforming how we view clinical trial development in this particular field. Randomized control trials may not be, feasible or practical in any way. To transition to the great talk that was made with regards to heart failure by Jennifer Kleiner, and then more towards a clinical cardiologist perspective, Matt Suffoletto, TR patients, how do we optimize their medical management, and what exactly does that consist of?
You want to start?
Well, so, if they have a low EF, then it's easy, right? We just use the same guideline-directed medical therapy that we have for patients, again, with mitral valve disease or isolated LV dysfunction.
So what about isolated tricuspid regurgitation? Is there like a target dose of diuretic that you're gearing up to do? And I mean, obviously, SGLT2 inhibitors and diastolic heart failure have been obviously, or HFrEF have been promulgated as a very promising therapy in these folks. I mean, are you trying to achieve the same targets? And what is your monitoring of a TR patient with right-sided heart failure?
So we're trying to get them as close as we can to euvolemia. That is very difficult in this patient population. So diuretics, we use them aggressively. We use them at high doses. SGLT2 has been wonderful to supplement, diuretics. I've been very impressed about the amount of diuretic effect from SGLT2. We do not up-titrate those, again, just the once-a-day dosing, but we have been successful in getting folks who historically difficult to manage from a diuretic standpoint with a fine balance of SGLT2 and loop diuretic.
Matt, any comments about
Yeah,
that? Difficulties with this patient population?
To jump in, actually, one of the cases I showed, which was the ventricular functional TR in my talk, where we saw these apically tethered tricuspid leaflets with a very wide jet, big gap. So that patient was an inpatient at the time. After those images were taken, she underwent inotrope-facilitated diuresis. She left the hospital on SGLT2 inhibitors, somewhat heroic doses of Bumex 3 times a day. And she came back to see me in office, and she said, I haven't felt this good in a while. She had no edema, stable kidney function, stable potassium level, and really was I wouldn't say asymptomatic, but her symptomatology improved. That I then kicked her back because we were bringing her in to screen her for Trilumin. I said, listen, she's doing really well. And actually, my partner Bill did a TE on her, and we can see that her leaflets are now coapting. They're less apically tethered. So we definitely impacted the degree of TR and how she felt and the anatomic position of her leaflets. So, in fact, we have her kind of orbiting now as far as do we try and enroll her to continued access or not. So that was a really gratifying case, and that's how we approached that.
Excellent example as to what can be achieved with medical therapy in this population. Turn over to surgeons with regards to durability. So what do we know about mitral valve repair durability, tricuspid valve repair durability, and do you think that there's a role of percutaneous therapy versus surgery trials in assessing that further?
I mean, if you look at, the outcomes that Dr. Bonatti, showed, your mortality with mitral valve, repair, surgical, open surgical versus mitral, it's a decimal point percentage. And, mitral valve repair, they're durable. And mitral valve replacement, no different than really any of the tissue valves that, the percutaneous valve would be. And so, I think definitely whether it's tricuspid, or mitral valve repair using clips, I think they need to be compared to surgical outcomes. Otherwise it's, comparing apples to oranges.
Any other comments about what we know about durability in the surgical arena?
Sure. What we cannot deny is a long-term freedom from reoperation, in the 95-90% range. So we have to prepare the patients for a reintervention, reoperation in the range of 5-10% over the coming years. What we also know is if the repair is good right after surgery, it will hold. So that's where we are.
Excellent.
One quick
Final comments, Dr. Yin?
One quick comment I want to make is the mitral space is very exciting because whenever I get a referral for MAC, for rheumatic mitral disease, it's one of the most treacherous, technically complicated operations that I face. So I welcome, the development of transcatheter mitral valve replacement. That's what's really going to benefit for a lot of these patients because the technical challenge of these type of operations is extremely difficult. And we have several patients at the VA right now that we're sort of struggling. Another comment I have about optimizing patient with right ventricular failure, TR, is that's one reason why the SAS database has the highest mortality for TVR, because I think many of us, including senior surgeons, do not know how to manage post-op tricuspid valve surgery as well. They go into RV failure. It's just the nuance of RV failure is really tricky. So I think that's what it's important for us as surgeons to collaborate with cardiologists before the operation, during the case, and afterwards to really get these patients through it. So that's
excellent. That's an excellent pointer. Some of the adverse outcomes that we've seen with concomitant tricuspid valve surgery in the setting of other valve/revascularization surgeries probably explained by that inadequate medical management, perioperative management.
What we hope, of course, for is that our repair failures can be treated percutaneously. How's the experience with that?
Yeah, and we have, Bill Katz has put together a nice paper of a number of the patients we've seen that have had failures of repairs, and they're more challenging patients. Thankfully, we have a variety of clips that are enabled us to do it. We've successfully been able to clip them without the development of that mitral stenosis that you can see that we know has adverse effects. So it's a case by case basis, but it's I think a nice option. Especially for some of these patients where a redo is would be a really challenging situation.
It's great. Not to cut off the discussion, but we do have to move on. This has been a really great section. Appreciate all of the great content and appreciate this very lively discussion. So we'll turn it over to the panel for the moderated live case that we did actually at our institution. And so we'll invite Sandeep Jain, Dustin Kleiner, Amber Makani, and Matt Stuffletter to stay. And I will show the case that we did. So this is not more of a voiceover thing that we did initially. We're trying to experiment with different formats. This one is kind of like a pre-recorded thing that I did, and then we'll have time, I think, at the end for comments. But I'll go ahead and share that case now.